Good morning, everyone. This is iBanking session of. This is iBanking Association of iBank Association.
iBank. Oh,
That's what iBank Association of India meeting. Myself, Shamor Bashak. This is Colonel Major General J.K.S. Pariyar. So we'll be having a relatively good crowd today in iBank interest are there. So we'll be starting with Martin. I guess Martin is not there. Then Sunita will be joining us a little late. So we'll start with Bangladesh iBanking. Bangladesh, the Ashraf, Hriday. Please do come here. So then we'll have Nepal, then Vision 2030, Sujata, then iBanking of Indonesia. Then in between we'll take the keynote address. Let's start with Bangladesh. You can start.
Good morning, everyone. And I must say my gratitude to the iBank Association of India for inviting me. And when we talk about the Bangladesh iBanking, the progress, challenges, and innovation, first, a little bit introduction about the Bangladesh. It's a country of South Asia, population, but it's a huge populated country of 180 million, and we have the population rank of 8th. It's a Muslim majority population. Our GDP per capita is USD 2500. And the eye health of Bangladesh, 1.5% adults are blind and 21.6% has low vision. 6 to 8 suffer from the corneal diseases. And primary eye care is available in all cities, tertiary eye care in the divisional cities. Total number of ophthalmologists, we have more than 1400 ophthalmologists. And now comes on the eye donation and eye banking. The first voluntary eye donation and cornea transplantation was done in 1976 in Dhaka, Bangladesh, which was done by late Professor Mustafizur Rahman. And first eye bank was established at 1982. It's more than 50 years. So the history has a long thing to say, but unfortunately, till now, the present scenario of Bangladesh, we have 5 eye banks approved by Bangladesh government, and in last 5 years, the total number of cornea transplantation in Bangladesh is nearly 3,000. It is mostly done by the private sectors, Bangladesh Eye Hospital and Islamia Eye Institute and Hospital. So what is the problem that divided in 1976 to 2008? By this time, what happened is that the unclaimed body, we have our high mortality hospitals and we could collect corneas from the unclaimed bodies. But we have some gadgets coming on. 2008 and 2018, the gadget goes on that the tissue transplantation system, they did not have clear instruction about the cornea collection, cornea harvesting system, so that after 2018, it getting low the collection process. But the thing is that when the local harvesting process is decreased, but our cornea surgeons, we have now 50 plus cornea surgeons, and we are getting all the corneas from US and Nepal right now. So the foreign cornea demand has been increased. And when there is the tissue needed and we are not getting the tissue, we refer patient to India or Nepal for the transplantation. And with the foreign tissue, what happened is that our surgeons skills becoming increasing because we are getting the pre-cut tissues. So we are regularly doing with the foreign tissues the PKP, DALK, and EK. But what are the demerits of this? The demerits for eye banking and cornea harvesting systems demerit for this is the functional eye bank established process is slowing down because we are getting tissues. The surgeons are getting a little bit relaxed because the logistics are here from the foreign corneas and no significant improvement over the years happening, and others are not interested for investing any eye bank. There no till last year, no stakeholders are investing for the eye bank in Bangladesh except the corneal surgeons. So I'm just, and another thing is that being the Muslim majority population, it's a little bit difficult to convince the Islamic leaders, but though we have all the data that Islamic Foundation and the World Muslim League has recognized and gave the fatwa that you can donate your eyes. There is no harm donating eyes in the religious view. So right now we are facing that religion view is not the problem. Our problem is the government gadget and the government recognition for the banking, start of the banking. And these are the thing that, so now the good part, that is the previous part before 2000 and 1976 to 2023. So we, the cornea surgeons and the other stakeholders from Bangladesh, we sat in a meeting and we decided that what we need right now for Bangladesh, starting the actual functional eye banking. We need the national guidelines for eliminating the corneal blindness, which is going on. Hopefully by next year, the Bangladesh government will publish it. And we need to involve all the stakeholders from a common platform with the government organization, NGOs, international NGOs, and the corneal surgeon and healthcare professionals, and the political and the religious leaders. Last year, we had several meetings with them, and sorry, and this is the result after having the several meetings. Mainly the corneal surgeons were involved for establishing the eye bank, but right now you can see the photos. We could establish a Bangladesh eye bank with the involvement of all the corneal surgeons in Bangladesh and also the other stakeholders, not only doctors, non-medical stakeholders, and the religious and the politicians leaders who will work with the government for this. And Bangladesh government has now formed a committee for making the guideline for eye banking in Bangladesh. I am also part of this committee member. And after this, we already started distributing the pledge forms, and it's going on. But motivation, it's going on. We need further work for that. And this is the present advisor of health in Bangladesh. We all the stakeholders of Bangladesh Eye Bank went to meet them, and the health ministry of Bangladesh is now going to help with us to recognize and establish the eye bank. But this is the thing, the instruction of things. But the thing is that this is still under process. We are still under the immature status. So to get the maturity in Bangladesh for eye bank, we will need time, and hopefully within few years, I will not say that next year, within few years, we can give you a good information that we can collect and through a proper system of cornea harvesting in Bangladesh. And by that time, I must say thank you to the Eye Bank Association of India and SightLife, Vision Share, and other stakeholders who are providing us the corneas, and Nepal Eye Bank who are providing us the corneas so that we can continue our transplantation in Bangladesh. So right now, in last year, we did nearly 2,000 cornea transplantation in Bangladesh. Thank you very much.
So, any question by any Sujata? Yes.
Yeah, Dr. Asrup, can you say how much cornea you get from which country? What is the proportion, just grossly, and how many you need?
Yeah. Basically, ma'am, their major cornea transplantation is done by 5 corneal surgeons in Bangladesh. So among the 5, 3 are working in one hospital and 2 working in another hospital. The 2 hospitals are working on, and we have the data. We need nearly 1,200 corneas per year minimum. And right now, the 80% cornea is we are getting from US, and 20% cornea we are getting from Nepal and Sri Lanka. So we have MU with Vision Share of US company and the Sight Life, so that we are collecting corneas, and from last 2 years we are getting also the pre-cut tissues. Pre-cut tissues, so that's it.
So my next question is that do you have in this figure your own collection?
Sir, yes, we have our own collection till 2018.
No, last 5 years no collection.
Last 5 years we didn't have any local harvesting, but yeah, we did only 4 local harvesting in last 3 years, because there was one uh, girl who donated her corneas, that was 2, and we could collect from one actor's eye. So that was the only local harvesting corneas in last 3 years, because the problem is that uh, we set up the eye bank in 2013, but we have some multi-specialty hospitals where we can start the HCRP.
Right.
But the problem was the local government. When we started the HCRP, they told that you need we need to have the permission from the local government, but we didn't have the authorization later. So that's why from last year we are sitting with the government first. So give us the rules and regulation, because previously that was the thing that the religious view people might not give the corneas, but
No,
it
that
has
is
been
not-
changed.
yeah.
It's a totally secular country, so it's not the religious view, it's the mindset up, it's the legal things, it's the publicity. So we are trying to do that from last 2024, and we already are working with the health ministry of Bangladesh right now.
So actually, I was going, that
Yes.
several times to only for eye banking, and I have several times I did all life surgery there and
Yes.
lot of training, wet lab, everything we have done. Well, ultimately there are several projects only supported by Rotary and all.
Yes.
We stayed there for 4 or 5 days, and somehow it didn't happen. My view is that we have an excellent guideline if you go to our website. So what is the medical standard of eye banking of India, and we have taken some from US eye bank, some we have our local logistics. I believe that same logistic will be there, and your government also support those logistics in Bangladesh. So maybe the interim period you have certain problem, but once the things will cool down, I hope that that is the challenge, major challenge to cool down the current situation. So we are hoping, because I'm same mother tongue from Bangladesh, so I believe that what he said, that it is right absolutely. From inside their heart they say that we will donate, but there are certain logistic by the government and other sectors, so it is preventing them to donate eyes. Thank you.
Thank you,
for
sir.
your-
Shamar Bashak sir is a big name in Bangladesh, and we all respect him. I still remember his one word, that whatever you work, you first take the permission from your government. If your government is with you, you can work. And we are following your word, sir. Thank you. And definitely, we will take the help of EBAI, and we'll happy to take help from EBAI. Thank you, sir.
Sunita. So Sunita, you can talk now. So Sunita is the currently the in charge of LBPI Eye Bank, Ramayama International Eye Bank, and she'll be speaking on beyond corneas, expand the scope of eye banking. Sunita, it is time.
Yeah. Thank you, sir, for the kind introduction and wonderful talk, Ashraf. So my talk is on beyond corneas, expanding roles and responsibilities. No, Sunita.
Please change the
Sunita
slides.
Chaurasia. I
Dr.
upload the
Sunita's.
speaker. Or else. I upload in speaker room morning. Sorry, I've not brought your, sorry? I haven't brought my laptop.
So-
Sorry about it. Otherwise, Dr. Sujata,
So,
or else,
so Minu, you can
Yeah, we-
present. So Minu is from Nepal I Bank, and Nepal I Bank is doing excellent work, and they are surplus, so they are actually supplying the tissue across the globe, especially in countries like Bangladesh. I know they are supplying to Indonesia and Vietnam. They are supplying. So they also supply in emergency purpose also, because I remember we had a live workshop in Vietnam, Ho Chi Minh City, myself and Aldabe for DSEC and DMEC, and whatever shipped from US to here, totally because of temperature issue, everything, we put the thermometer in and we saw that it is 46 degrees Celsius. So we reject all 35 tissues. The patients are waiting. We stayed 1 day more. SOS call to Nepal I Bank, and Nepal, Vietnam is close by. So yeah, so you are ready. So we got the tissue, not so many, but 13 tissue came within 24 hours, and we did the surgery. Now, Sunita, yes.
yeah, sorry, the technical glitch. So I will be talking on the topic beyond corneas, expanding the scope of eye banking. Now, if you look into the evolution of keratoplasty and its milestones, we see that following the first transplant by Edward Zerm in 1905, only a few improvements were made over the next 100 years, which involved mainly the microscope, sutures, antibiotics, and steroids. But there was little change in the surgical technique per se. But the year later on from 1990s has seen a sudden explosion and a rapid explosion in more selective corneal transplantation techniques, especially so in endothelial keratoplasty. So if you look into the trajectory, 1998, Gerrit Mellis first proposed the term posterior lamellar keratoplasty, which was replacing the diseased endothelium with a donor cornea of posterior stroma and endothelium. 2004 to 2006, Mark Terry, Price, and Gorever popularized the same technique in US as DLEC, DSEC, and DSAEK with the automated technique. Mellis introduced in 2006 the DMEC procedure. Simultaneously, endothelial cell injection therapy work started in 2000 onwards from Nancy Joy's work in 2000, where she discovered that the human corneal endothelial cells could proliferate and replicate under special conditions. Year 2018 saw the Kinoshita's landmark benchmark paper, which talked about successful outcomes of endothelial cell injection therapy in pseudophakic corneal edema. And this year we know that there's a commercial availability of injectable endothelial cells, Visnova, where generic name is Neltependocel in Japan. Results of Clara trial, which is on the cell therapy along with rho kinase, is likely to be available this year from the US. DALC surgery was popularized by Anwar and Teekman in 2002, and this has become standard and reproducible technique in management. So when we look into it, the eye banks, which initially began with the traditional roles of collecting, preserving, and distributing corneas, have gone through a sea change, and eye banks have kept pace with the changing practice patterns and the new techniques of keratoplasty. And the present-day eye banks not just have cornea collection, they have expanded roles and responsibilities to address to the corneal surgeons. Beginning with, in many years earlier, it was the clinicians who used to perform the cornea evaluation. Now it has purely become technician-based donor cornea evaluation in several of the eye banks. Subsequently, the pre-prepared tissue for DSEC was introduced, and this was a natural consequence of increased popularity of endothelial keratoplasty. Now, this was again important because this significantly reduced the surgical times and unwanted delays and cancellations which happen as a result of tissue preparations in the OR. We have also moved on to the pre-prepared tissue for the DMEC surgery, and while DMEC is available, pre-strip roll is available in India, the preloaded DMX scroll is available in the US and many parts of Europe as well. Amniotic membrane is another intervention which is done in the eye bank for procuring and preparation for surgical use of various ocular surface surgery. So this is again one area which is very specialized and way of preparing the amniotic membrane, which is utilized for several of the corneal procedures. Scleral tissue, which is procured at the eye banks, is used for glaucoma shunts and patch grafts for corneal immune conditions. If you look into the future of eye banking activities, what is going to probably happen is integration and delivery of translational research technology which will be adopted in the IBanks, and this will be the need of the hour in the future. Now, to begin with, there's a lot of work which has been already done on corneal equivalence and cellular scaffolds for corneal diseases. And these might probably be, the distribution may happen through the IBanks in future. We also have heard about the growing interest in tissue adhesion surgeries for keratoconus and hyperopia. So component corneal tissues may also become we may also be something which will be taken up by the eye banks, and the preparation of these lenticules and corneal tissue segments, either freshly prepared or irradiated using gamma irradiation, will be taken up in the eye banks. There will be a requirement for long-term preservation, and some of the desolarization processes may be adopted in the eye banks. Corneal lenticle preservation from routine surgeries like SMILE and silk may also be explored as possible source of biological tissues in future. Thereafter, we also have, in the past, cultured epithelial cells were already provided by the eye banks, but it is a possibility that the provision of cultured stromal and mesenchymal stem cells for managing the stromal scars and other disorders may also be, the contact point will be from the eye banks again. Same as for the engineered and cultured endothelial cell therapy for the endothelial diseases. So in future, probably this is just, we don't know when it's going to happen. So this is going to happen. I'm just talking about the global picture. Probably the eye banks, the nomenclature might shift from eye bank to cell and tissue bank in future. Thank you for your listening.
Any comment or question to Sunita? Anybody in the audience? No question to Sunita?
No question, because she has already explained in the future path. The cell, yes, about the lenticule. In fact, the lenticule expansion technique has to develop, because the lenticule, it may be 40 micron or 70 micron, not more than that, and the tensile strength is too less. Then it's a very small button, maybe 5 millimeter, 6 millimeter diameter. But yes, it's a good idea when you think something will come in future. So I feel that this may be a nidus for further expansion of the corneal tissue, the stromal development. So sky is the limit when you think about innovation and research. Whatever looks impossible today to even think will definitely come. Like our generation, whatever now we are doing, myself and any one of us, we had never even dreamed during our residency days 40 years ago. So it's a good presentation and well insight, and I am sure what we have said about the cell and tissue, it will come. And then EBI will also change its name.
It'll change to tissue bank, eye and tissue bank.
So
Yeah, many people ask that whether the eye bank will be closed after doing all those bioengineered cornea. I'm think it will not close. What
it
do you
will
think?
not, because these are all expensive procedure though. Do you have any idea what is the cost of this in Japan about the
I think
this cell?
Inosita was mentioning in.
Yeah, that is we know that. What was the cost he told? I think
I
it is
think
much
them
more.
6 lakh, but he says 90% is or 90 or 95% is borne by insurance, and rest
That is
5%
there.
have
That
to
is
be-
there.
that is
They are
Japan.
in Japan. But whatever I was told that it is much more, and probably it is in Indian currency. It is close to 1.5 crores. But if you whatever I had discussed maybe a few days back. So that is one aspect of it, and the lab is, that lab setup is, so it has to be given to commercial people. So already America is doing it, so next year American people will come. Probably that time the pricing will be reduced, and how many patients of our could afford those. So that is one side, the research and translational research to give to the patient. Another side, our system of Indian eye banking, whatever I feel that it is much patients friendly. When I talk, you also talk the same. Our total cost come to for DMEC is like $500 to $700. Will people get shocked? How come it could be? So this thing will go parallelly. We know that So future is always there, and we have to like all these things to be considered. So, Minu, it is your turn now. So they have a nice system of iBanking in.
There will be always scope for. If you have Mercedes, still you are going with the e-rickshaw. If you have Parihar and Basak is a Mercedes, still I have the scope.
I would like to thank the iBank Association of India and the Asia Pacific Academy of Ophthalmology and AIOS for giving me this opportunity. So, like Dr. Basak has said, Nepal has a very beautiful journey for iBanking, and I would like to say I have no conflict of interest and no financial disclosures. So in Nepal, why did we actually need an iBank? Because it's a very small country like Bangladesh, but it is not so heavily populated. So we found that we also have a very large burden of the global blindness. And when we did a survey, and what we see in the survey in 1981, the blindness was about 0.84, and in 2010 and 12, when the RAB survey came, it was 0.35. But if you see the number of blind, they are nearly the same. It's not very different. And when we see the causes for blindness, the corneal blindness in our part of this country was about 6%, and corneal blindness in children was quite high. It was about 45%. And because it is an agricultural country, even though people are doing many other jobs now, but still corneal trauma and corneal ulceration was the major cause for corneal blindness. So this journey of Nepal iBanking actually started from 16th of September 1994, when the first iBank was established, which was situated in the Tilganga Institute of Ophthalmology, and it was inaugurated by our prince, who is not there anymore. There was an assassination, this thing, in the royal family. And now today our iBank is actually recognized for very good quality of corneal tissue, and also as a training center for the iBankers. So this Nepal iBank today is associated and accredited by the SightLife, the EBAI, the EBAA, and now I think the Cure Blindness is also in the scenario. So initially, like Bangladesh, even Nepal was dependent on other countries for their corneal donations. So we used to have very little corneal donation, and like we used to nearly get about 243. You can see the data there. We used to get these corneas from outside, and see I think this is something very different. Our iBanking was, or it is still known as the temple iBanking, because the crematoriums, we have the Pashupati Nath temple, which I think everybody knows about it, and it is situated on the rivers of Bagmati river, and that is where the cremation normally in Hindu religion it takes place. So we used to actually go and ask the dead persons, the kin and the relatives, to please donate. So that is how this temple iBanking, the name came, because it is at the rivers of the Bagmati near Pashupati Nath. So you can see the Pashupati Nath temple there. But then slowly what happened, it was becoming very difficult to get corneas by asking them, because they put a lot of abir, or this is actually the vermilion which they put when somebody dies, and the corneas were getting like they were not very good quality cornea. So we had a little bit of more challenges. So we thought that we should go for other systems. So initially, like when we started, we didn't have the iBanking system was not very good, because we didn't have many trained corneal surgeons. We didn't have any national strategy for about nearly 10 to 15 years when it was started. And like we said, it is already only dependent on the voluntary donation, and it was limited only to the community awareness and education for this iBanking. So now then what we thought is, what should we do? So we thought that we have to eliminate this blindness, and our mission was actually to establish a National Eye Center for iBanking as per with the International Eye Standard. So we set a goal of about 1,500 plus corneal transplant were needed. So what we did is, we got accreditations for this small eye bank from the International Tissue, from the American Eye Bank Association, from the Eye Bank Association of India, and also from the SightLife. So now when we see this journey, now so what has happened is, in 1994 we started the eye bank, we partnered with the Lions and the Rotary, then we had this Temple Eye Bank, we partnered with the SightLife, And when the site life actually came, we started with the hospital cornea retrieval system. And that is where the university hospital where I work. So in that, from that particular hospital, which is the Tribhuvan University Teaching Hospital, we are nearly collecting now about 700 to 800 to now even 1,000 corneas in a year. And these are all good quality corneas. So now we have a lot of surplus tissue, like it's going to the foreign countries. We are doing this pre-cut tissues also for DALC, for DSEC, DBEC, and also we have now started the amniotic membrane. So we have now entered into a new phase to the hospital cornea retrieval system now, which is in conjunction with the crematorium-based or the temple eye banking, and also some of these contributions from the voluntary eye donations. So this is my hospital where we excise, or we take the whole globe also, or we take the cornea. So our EDCs are there. They do a very good job. So these are our different hospital from where we can collect corneas. The one from where we take the maximum number of corneas is the teaching hospital. We also have the Beer Hospital, the cardiac centers, the Patan Hospital, and from the electric crematorium, which is now working very efficiently from where people are donating. And like already Dr. Basak has said, we have a lot of partnership and support from the different eye hospitals in Nepal, all over, from the different zones and the regions. And we also have collaborations with the different societies and the trust, like the Pashupati Trust. We have the Nepal Cornea Cataract and Refractive Surgery Society, the Nepal Ophthalmic Society, the Eye Donation Society. So we have a lot of these organizations which are helping us. And now, like we said, we started with a very small number of corneal tissue, that is 2. Even when we started HCRP, we just had about 6 or 7 tissues we got. But see, today now we have nearly crossed 1,500. So now we are aiming for even more so that we can help our own corneal blind people, and we can also, we are actually giving it outside, and surplus is giving outside also. But I think the problem that we are having in Nepal today is we are still struggling with therapeutic keratoplasties and full thickness. We are doing DMEC, not so much of DMEC and DSEC or DALC, because I don't know, we are still struggling with that part. And because most of our corneal surgeons are actually so busy doing cataract surgery, they are not doing their corneal surgeries. So like we have different parameters to evaluate for eye banking. And we have our own values, it is also dependent on accessibility, sustainability, and awareness and education. We have a very good awareness and education for eye banking. So the current scenario is that we have a tissue processing fee for our tissues when we send them outside, or even to the corneal surgeons outside, which is very minimal. It is not the corneal tissue, but it is actually only for the processing fee. So that way the eye bank is able to sustain. And like we said, we also have these the eye bank is supported by the banks also, because it is under the corporate social responsibility. So the banks are supporting eye donation societies, their social support from different social organizations. So I think Nepal Eye Bank is doing a very wonderful job, and we are able to sustain ourselves. So our sustainability is based on 3 principles, which is economic, environmental, and social. And we also have an informal sustainability in the form of profits, planet, and people, because we need profits to sustain our eye bank actually. So like for this sustainability, it's very important that we are utilizing our tissue, which is maximal utilization, and we use this tissue for research and training whenever required, and the disposable is done according to the WHO standard, which is very important. And even the economic sustainability, like I said, we are asking for a processing fee, not for the tissue. So we have the government policy where under insurance policy, the transplants are paid by the government, and there is no commercial value for these tissues. We don't have actually any legal form of any binding, or we don't have any license, that type. Like in India, I think you cannot transport your tissue or export your tissue. So till date, we don't have that. So I don't know, maybe we have to do that, or we don't have to, because if we do it, then we'll not be able to send it to Bangladesh. So we don't have that type of system in Nepal till now. Our legal system has not taken that into account. And like we said, we are very self-sustainable. HCRP is doing a very wonderful job. And social sustainability, like we've been doing a lot of awareness and education. And I think because it's Hinduism plus Buddhism, and in Hinduism, I think that was the first slide which I told to everybody. Whenever the transplant was done, Lord Shiva himself transplanted the head of his own son Ganesha with an elephant head. So we are the first transplant people in Hinduism, whether it is Bharatvarsha or whatever. So I think that is where people are quite like they are quite aware and they want to donate now. So they come to us, so we have these papers, so it's very good. So I think that is all I have to say. So we have a very good banking and people are totally doing it on humanitarian basis. Thank you so much.
Thank you, Dr. Meenu, for excellent presentation, and we are definitely looking forward much more work from the Nepal Eye Bank. As such, it is highly commendable. And things it starts with the PK only, and I think that depends upon the demography, the type of cases you get it. Yes. If it is a rural area cases where the injuries and infections are the predominantly engaged, obviously the PK is there. And second step will come, and the tertiary, when you switch over to the DSEC and DMAC, yes, for sir. That you can take help of
yes,
any...
Yes, sir. Dr. Samar Basak
yeah,
has come.
Dr. Samar,
Sir,
that's
actually,
I was telling. You can take it help from the
yes.
this Dr. Basak, you can take it from the PGI,
yes.
RP Center.
Yes.
And when you have mentioned about the Virat Nagar, I have a nostalgic memories of working in these areas through the armed forces medical services in 1987-88.
Okay.
I was stationed in Dharan and doing the cataract work as well as promoting the eye banking and other activities.
Okay. Sir, actually, I think our surgical training for cataract is quite good. So even PBK is not so common. PBK, Fuchs dystrophy is very less. So
one of my students from the Nepal army, Ramesh Bisht.
Okay, yes, yes.
I trained him in FMC way back in 98-2000.
Yes, he's there.
What is the utilization rate, Meenu?
Utilization is nearly 80%.
80%.
This data is for only Nepal Eye Bank or through the country?
No, this Nepal Eye Bank data is from everywhere, the whole of the country.
So this is like
Because
a society,
we
like
sent our
EBAI,
reports.
You have a society for
Sorry?
Nepal? Like EBAI, you have a central body for Nepal?
Yes, yes, yes.
May I invite our dynamic secretary, Dr. Sujata, to present her.
Good morning. After listening from our two neighboring country, one who is no cornea collection and who has surplus cornea, I think India is in between the transition stage. I think this symposium is really APAO because we have representative from many countries. So I'll part of this thing is covered by Sunita also because what will happen in 2030. So I'll just from EBI side will tell about the update of the collection and what is the goal. The goal is to improve definitely collection and utilization rate. Like Meenu told, they have a utilization 80% in India is not the scenario. And quality control like accreditation, and I always dream of graft registry, and Nepal is already sending tissue across the border, whereas in India we don't have. So this statistics is few years back. I don't know whether it is correct or whether we is worsened or improved. Because if you ask many eye banks or many cornea surgeons, they say they don't have a waiting list. But I believe it is not uniform around. Maybe some people in the rural areas still waiting. So that time, as for the calculation, we require 2 lakh cornea to be harvested, thinking that 50% utilization. Even if we don't do 2 lakh, because if you see the graph, it is like a really a V shape. The highest is 27, like to 58,000. So compared to 2 lakh, even if we don't reach 2 lakh, I think if we improve the utilization rate by doing 1,50,000, we may do 1 lakh collection. So to reach 1,50,000 also, we need to improve 3 times. So the calculation that time per 2 lakh is 4,000 cornea per year from one eye bank and 50 eye bank. So this is the current scenario of the eye bank number. At present we have 740, but if you see how many are collecting above 1,000 is 14 eye bank. So we need 4,000 cornea collection from 50 and above 4,000 is only one iBank, and 14 iBank is above 1,000. So the planning for collection by 2030, that we need more collection center rather than iBank. iBank is a glamour, but to run the iBank is not easy. So iBanking activity is mostly localized to few metros and few bigger institute. It should be in the different part of country. And training center, we need training center, at least pipe zonal training centers. And most of the, like Minu mentioned, and all of us know, HCRP gives us good quality of cornea and more utilization. Also, a lot of coordination and maybe government help is required to improve our HCRP collection. At the same time, spreading awareness in the community. This was long back in 2020, 2010. You can see different zone collection and utilization. So it's always South Zone who leads the show. So you have to focus on different zones to start iBanking activity. Coming to utilization, how to improve utilization rather than collection. So as I was mentioning, we may not collect 2 lakh, we may collect 1,20,000, but if we increase the utilization rate, we can reach the target. Focus on more lamellar surgery. As Dr. Parihar was mentioning, from the where the patient come, it is not, one is from where, and the most likely will not, lamellar surgery will not more than optical or penetrating in India even next 50 years, because infection is major component. And training of cornea surgeon, luckily now most of the cornea fellows who go to their place, they get cornea because of the corneal distribution system. Still we need lot of cornea surgeon, and well designed cornea distribution system, it is there but is not completely like working out. And more transplantation center, again we need help from government. And tissue transportation is big challenge, because many of the airlines, they don't carry the tissue. Even if they carry, they charge heavily, so it has become a difficult. And quality control accreditation, again, Nepal iBank was accredited by EBAI, but however it was with Site Life, sometime it was with, but NABH has not taken into account for the, or any organization, so maybe EBI will do the accreditation and give the iBank. For that, we need to train lot of assessor, and who will accredit either EBI or in addition to EBI, NPCB or NABH. So graft registry is available in many countries to know the long-term outcome of many grafts. So in India we don't have. Otherwise some institute have their own, but if you see the throughout the country, we need a graft registry. For that we need a strong database. Again, the manpower should be trained. And more main challenge, I've spoken to Dr. Basak also, he says always you start and let us see the proper documentation by cornea surgeon. We struggle for the recipient form, so it will be a big challenge. The cornea surgeon should be documented as for the format if you want to do this. And this is a big question mark, but I assume in 2030, India will have sufficient tissue to send across the border, at least to start with therapeutic tissue, because many countries in Africa, they don't have even tissue to do for emergency purpose. The bottom line is, even if it is a therapeutic tissue and people are waiting, no tissue should go waste due to lack of recipient. We say that we have a lot of waiting list. We did this survey during COVID, and you can see this graph, you see that 1.6% has only 90 to 180. So almost 98% surgeon, they have a waiting list less 90 days. So I don't see many waiting lists in major places. So for that, to convince government, we need legislation, we need to have epidemiological data about the demand supply gap, because the calculation extrapolation was long back, maybe 25 years back, and we need to change in legislation. So this already Sunita has mentioned, we should focus on utilization and usage of intermediate cornea storage solution. I know many iBank, they have moved completely to intermediate storage solution rather than short-term storage solution. And like processing fee, in many forum people ask what is the processing fee, but we have to change from charity model to self-sustainable model. It may not be profit making. And in future, EBI may be eye and tissue bank. So this first part is already many iBanks are started sending. And DMAC roll from Ramayana iBank, we send to DMAC roll to everybody. outside this, and IN tissue bank in future, we must be doing IN tissue bank. So way forward, we should start in all states, and iBank training center in different zone for eye donation counselor and iBank technician. I feel this should be combined, donation counselor and technician. This should be multi-purpose. And this I always feel many graft we lose because the ophthalmologist, they don't know how to manage corneal transplant. So general ophthalmologist should be trained and more trained corneal surgeon. And more lamellar surgery, we can have a survey, epidemiological information about corneal blindness in different part of the country, corneal registries, mandatory accreditation, all these maybe by 2030. So we have 5 years in our hand, involvement in advocacy and policy making. Thank you.
Thank you, Sujata, for this overview of current status of iBanking. But a few comments like for Government of India, blindness is not a problem in our country at present. Because we have worked together as a AIOS president, I was working for last 1 year, I really thought why. So NPCB is not there now. NPCB is shifted to NCD, non-communicable disease. iBanking was a major part of our NPCB work, we knew that already. So from our broad perspective, the cataract, last year we have done 9 million cataract surgery. So blindness coverage is done. So right now the prevalence of blindness in India is 0.25. Whereas it was 1, then target was 0.35, then it is 0.25, target reached. So they will not churn up the NPCB again. So iBanking, whosoever doing, it is our own. Government support probably will not be there because last few years we are not getting government support. This is from what is my understanding with the talking with the government official. Second thing is that data gap, there is a huge data gap in all sector. But consider what you are telling, that is correct. The waiting list of majority of the iBanks who are doing in huge volume of keratoplasties, we know there are least number of waiting lists, zero waiting list. You always say that I have almost zero waiting list, right? Your place, our place may be 20, 30. Arvind, those are big institutions. They are doing more than 1,000 keratoplasty every year. But if you really say that, what is the actual number of corneal, I call it transplantable corneal blindness, not corneal blindness. So if you consider the transplantable corneal blindness, and if you take the last RAB data of 15-19, they say the corneal blindness is the second largest cause of common blindness after cataract. If you put that data in our 1.42 billion of population, then you take the percentage, you take the prevalence, and it comes to 4,20,000. I have written that in my guest editorial. 4,02,000 is the number. So if you take the transplantable corneal blindness among these 4,02,000, so maybe 10%, 15% from our regular, you cannot take all the corneal blindness into transplant. We see what is prognostically much better, so that no tissue should go waste. Therapeutic keratoplasty is one thing, but for optical reason, we do not like, you also do not like, many people do not like. Why? You are doing more problem to the patient, for his or her quality of life will go after transplantation. So it is better not to. Likewise, we do not do one-eyed mostly where the prognosis is very poor. So these are gap. Regarding third comment is regarding NABH accreditation. Recently we have the full accreditation has been done in our main hospital. And they have checked our iBank also. In-house iBank, it is included in their thing. And that is also, they have seen each and every corner. They have spent almost 3 hours rather than spending more time in OR or other things. And they see all the records, whatever the points. We have shown that these are the 16, 17 forms and other things and all database, all computerized, EMR, whatever is there. And it is included in our NABH accreditation system. So my understanding, again, there is no clear-cut guideline, but if you have your own iBank in your own institute, like Ramayama International iBank within the institute, and there are many like RP Center and others. So if NABH accredited the whole system, iBank automatically will be included into it. So you will be, and last time when they visited, they raised 4 or 5 questions, we have corrected it, I can see corrected. And so
No, NABH in Bhubaneswar also, they come to iBank, but they spend hardly 15-20. They raise NC. Maybe somebody who is an iBank person who was the assessor.
no, maybe, but still feel legally, medico-legally, we are in a better place now.
They come to iBank, but they
But standalone iBank, I do not know how it is possible.
Sir, even, but in the, as a total NABH in a fifth NABH standard also, but the iBank is not included in their objective elements. We may have in our scope
But
of
whatever
service.
total
In a scope of service, you can add it, but when they give certification, they don't write ophthalmology, iBank
no,
separately.
they don't write. They give whole the structure.
Yeah, it's an eye hospital.
Right. So, okay.
Swati wanted to
So-
say something. Swati?
No, standalone iBank, that is a real problem, and okay, we'll discuss that. So I will invite Arundhati Anchu, and she is from Singapore, and the evolution of the role of iBank in the era of lamellar surgery, very much relevant in current scenario. I am not a stakeholder.
You are a stakeholder.
It is state to state variation. You cannot uniform it. You cannot uniform it. That is the problem. Problem with the state level. Problem in the state level. So there is no uniform guideline from the center. So please, Arundhati, yes.
We are now running short.
A very good morning, everyone, and thank you to the iBank Association of India as well as to APAO for inviting me to give this talk on the evolution of iBank in the age of selective lamellar keratoplasty. I'm Anshu, and I'm the clinical director of the Singapore iBank in Singapore. So the blindness due to corneal disease, we know it's the 6th leading cause of vision impairment globally, and over 12 million people the world over need corneal transplants. But only 1 in 70 eventually get a cornea. So these are staggering figures, and of course this is from data taken in JAMA in 2016. And so if you look at Singapore itself, the top indications for corneal grafts in Singapore for us would be PBK, failed grafts, Fuchs endothelial dystrophy, so on and so forth, which might be slightly different from other Asian countries around Singapore. And again, you know, we do surgeries for optical, therapeutic, and tectonic indications. And typically for us, with the advent of lamellar surgery, a lot of our optical grafts are today only lamellar. We hardly do penetrating grafts for optical indications. So this targeted replacement of diseased corneal layers was indeed a paradigm shift, because this was aimed at only treating diseased cornea, and this has led to significant improvement in corneal graft survival in the long term. So we've had anterior lamellar keratoplasty techniques, we've had posterior lamellar keratoplasty techniques like DSEC and DIMEC, and DSEC and DIMEC has really changed the way we do corneal surgeries today. DOLC has been challenging, the learning curve has been steep, so the take-up rate has not been that high. But with these change in mindset and the way we do surgeries today, the iBanks around the world have had to also adapt. And this has posed a significant challenge to the iBanks, and they have actually been very good at making sure that they provide us with excellent quality corneas that are necessary to improve vision. So the eye banks have expanded their capabilities in order to meet the needs of the surgeon as well as that of the patient. Because each type of lamellar graft has its own unique tissue requirements, and donor acceptance criteria and parameters have also had to become more specific. So there was initial hesitancy by the surgeons to take on pre-cut tissue, but when there were a lot more published data to show how it was good not just for the patient but also for the surgeon in terms of reduced operating time, taking the whole burden of having a complication during surgery when you're doing a corneal tissue preparation, led to an improvement and enhancement of the care that we offer to our patients. And open container processing performed by eye banks for DSEC and DMEC has now gained widespread acceptance. There have been some reports of microbial, specifically fungal contamination in the eye banks that are processed for EK specifically. But again, there have been changes that, especially in Singapore, I will be sharing with you in a short while, what we have done to reduce that incidence. And we don't have any fungal contamination in our processing in Singapore. So the eye banks are now looked upon as a value-added service to the surgeon. So I'm sure everyone knows here what the EBAI stats for corneal transplants in the US are. In the last 10 years, there has been a significant change towards doing lamellar surgeries, specifically EK surgeries, which have accounted for nearly 60% of all grafts performed in the United States, followed by PK and then ALK. So ALK still remains low compared to PK in the US. And if we specifically look at EK, in 2014 when DSEC was first started, it was the primary form of posterior lamellar surgery, and slowly and gradually DMEC has taken over DSEC surgery, at least in the US. And what about Singapore? In Singapore, for the last 5 years, and gradually DMEC has overtaken DSEC as the predominant form of lamellar surgery. And this has been because of several reasons. One is the availability of pre-stripped corneas provided by the eye bank, the excellent clinical outcomes that have encouraged our surgeons to start performing DMEC. And I'm sure the numbers will only continue to increase. So this is just a timeline of how we have evolved in SNEC since the inception of the corneal transplant program in 1991, which is predominantly penetrating grafts. And in the last 10 years, we now do more than 80% of grafts as lamellar surgery, and we hardly do PKs except for the very, very severe therapeutic cases that come in from our region or the neighboring countries. So what this impact has been on eye banking is that surgeons have become more stringent in their tissue requirements. I don't know how it is in other parts of Asia, but in Singapore, every surgeon has a donor-specific requirement. Some want a cell count of 2,500, some want a minimum of 2,800. So of course, we have come up with certain guidelines based on what our published data is, because everyone's worried about dislocation and primary graft failure rates. So we do have a dossier where we collect information on all corneal surgeons in Singapore and their tissue requirements, so that when we are in the process of distributing the corneas, we do make sure that they get what they need, because we do not want cancellation of surgery or wasting of the cornea. There are also new donor evaluation criteria, donor exclusion criteria, because now, especially with DMEC, we can use corneas that have scars, large arcuses, which have pterygium, and even previous LASIK surgery. And of course, donor age requirements have also evolved between DSEC and DMEC. With DMEC, of course, we try not to use younger tissue, as we all know, because of the difficulty in stripping the DMEC tissue. Other issues would be diabetes and jaundice. Initially, when we started the DMEC processing program in Singapore, we were not taking corneas from donors who were diabetic. But recently, we have started selectively, based on a grading scale that has been provided by US, we have started doing some cases, and we've done, I think, 4 or 6 corneas now with patients who are diabetic, and we've had no issues whatsoever. More importantly, with the launch of DSEC, we have to make sure that when our tissue coordinators and our EDCs go to collect or harvest the tissue, we have to make sure that the rims, at least 18 millimeter trephine is used, so that we get adequate rim for DSEC technique. What is also important is this important communication that I was telling you about between the surgeon and the eye bank so that the patient gets the best outcome. And the Singapore Eye Bank has therefore developed their own corneal grading system, which is grade A, grade B, and grade C, depending on several criteria like tissue freshness, stromal clarity, and endothelial cell density, because then that allows us to provide the appropriate cornea to the patient who needs it. In order to make tissue offers more efficient, our eye bank maintains a dossier on individual corneal surgery parameters so that we can allow them to give quickly the cornea that they need. This is a very busy table, but it is very comprehensive in telling us what are some of the tissue requirements for ALK, DSEC, or DMEC surgery, for example. So if you have a patient who's got ocular surface disease, as an example, you would want to have cornea that's got an intact epithelium. If you have a patient with DSEC who needs a DSEC surgery, we need to first of all make sure that we have adequate donor corneal stromal rim, and the patient is not very young, not in the, I mean, if they are young, it's still okay for DSEC compared to DMEC. And for DMEC, of course, jaundice and diabetes has been a concern, and of course, younger donors may not be that suitable. So these are some of the parameters that the eye bank professional keep in mind when they're determining which cornea goes to what kind of case. We started pre-cutting in 2011, and now today we have developed in such a way in terms of the published data that we have, more than all of our 100% of corneas that we supply for DSEC are pre-cut by the eye bank in the Singapore Eye Bank. And as I mentioned again, it is very, very important that when we recover corneas, we have to ensure adequate rim size of 18 millimeters using an 18 millimeter scleral define. This is the typical pre-cutting setup we have in the Singapore Eye Bank. We use the Moria Evolution 3 ALTK unit with an ISO class 7 clean room. There's an operator who is the TC who does the procedure and pre-cutting, and a circulator who helps this operator. We essentially have an ultrasound pachymeter, an infusion sleeve with IV bag, so that allows us to do very, very precise cutting. So since we started pre-cutting our tissues for DSEC in 2011, we have so far done over 2,000 procedures, of which our success rate has been 98%. And 94% of these cases have been released for a successful corneal transplant. The mean posterior lenticle thickness has been about 100 microns, and between pre-cut and post-cut endothelial cell count, the average cell loss has been less than 1.2%. And internally, if we have cell loss of greater than or equal to 4%, we do not offer that tissue to the surgeon. We very meticulously record all the pre-cutting data and analyze it to refine our algorithms further. Every month, we do an environmental monitoring of the lab, and we report any bacterial or fungal infection in recipients, and so far we've had none. So what's the advantage of having an eye bank prepared tissue versus a surgeon cut tissue, which I'm sure every one of you know here? The biggest advantage for the surgeon is that the stress is reduced, the operating time is reduced, and of course there is enough data to show that surgical outcomes are superior, if not better. But from an eye bank perspective, I think the most important thing that pre-cut tissue allows us to do is that it allows for quality assurance even after processing, because we make it mandatory to have a slit lamp exam and specular microscopy after we've cut our tissue. So this is how we do quality assurance for our pre-cut corneas. We do a mandated slit lamp exam, a specular exam, both before and after processing. We have an AIOS2025 machine that helps to determine the exact posterior lenticle thickness and cut profile. And this has now made it very easy for the surgeon to determine and tell us that, okay, I need a less than 100 micron cornea, then we will try our best to see how we can accommodate that. This quality assurance is important because it allows the eye bank to meet the standards of quality and safety and provides confidence to our end users, the surgeons, that our tissue conform to expected international standards. Going on to DMEC, again, we started a slow start because we were a bit cautious about how the long-term outcomes were, and there were reports of how there were greater risks of iatrogenic graft failure and dislocation rates in the early days. And we were in the process of iterating our technique as well. So from 2017 in Singapore, we launched the pre-stripping DMEC donor program, and in 2018, we introduced the DMEC Endoglide. And that has really changed the way we do DMECs, and that is why the number of DMEC cases have gone up. So this is just to give, again, a timeline between November to December 2017 to April 2019, where today we are providing pre-stripped donor tissue to more than 99% of corneal surgeons in Singapore. What is also important for all eye banks and not just within Singapore is that we continue to learn, because techniques will evolve, newer techniques will come on board, as some of the other speakers have said earlier, that there is constant evolution. So we continue to see how we can improve our techniques by getting experts in the field from the US to teach us and give us tips. And this is basically a concept of train the trainer program, where we learn and then we pass on that knowledge to our juniors, so that we can make sure that the results are consistent and reproducible. This is what our typical eye bank form is for pre-cutting. There's a diagram especially for DMEC tissue, so that the surgeon knows if there are any corneal tears or anything that will be of concern for the surgeon to take note of. And this is our data from the pre-stripping that we've done in the last 5 years. More than 600 procedures with a stripping success rate of 98%. And as I said, the donor age, the donors are older in our cohort, and the rebubbling rates have been much lower with 9%, and only one patient with primary graft failure in our series. What's the next step? So next step, we are moving towards preloaded DMEC tissue. We've just conducted a pilot study, and we've shown that it helps to reduce surgeon operating time without any significant risk of any intraoperative or postoperative complications. Of course, we need to do a cost-benefit analysis, because this is going to be definitely a lot more expensive. The other challenge that we've had, and we've come to know from the EBAI Medical Advisory Board, is the fungal contamination in eye bank processed corneas, because of the repeat warming that is needed to allow processing and post-processing assessment of corneas. What did we do at the eye bank in Singapore was that we got in an incubator where the temperature was consistently maintained at 35 degrees Celsius, so that it shortens the overall warming time before examination and evaluation of the cornea. We are very stringent. We track any culture results from the donor corneal rims, and these information is then passed on to the surgeon for immediate appropriate action. And fortunately, we've had no fungal infections in our recipients to date. So to summarize, the eye bank recovery and tissue processing have evolved in tandem with the shift from full thickness to lamellar keratoplasty. The surgeons and the eye banks must agree on acceptance criteria and tissue parameters for the different types of lamellar keratoplasty procedures. Pre-cut corneas for DSEC and pre-stripped corneas for DMEC have gained acceptance given the track record of safety and quality, reduced surgeon stress and operating time, and overall convenience. And the eye banks the world over, not just in Singapore, have proactively taken steps to address and mitigate the occurrence of fungal contamination in eye banks, especially for EK corneas. As newer and better forms of corneal transplantation evolve, the eye banks will always be there to provide support to all our surgeons. So this is thank you. This is the fantastic team that I have in the eye bank in Singapore.
We'll call
that works
next
tirelessly.
Yulia, Dr. Yulia.
We are short in time.
Okay.
Not able to take questions. We'll go next to Indonesia. Dr. Yulia will speak about eye banking in Indonesia.
Check, yes. Okay. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Thank you very much for the slides not yet. Okay, yes, thank you. Thank you for the opportunity to the Indian Eye Bank. So now I will talk about the eye bank in Indonesia, how we developed the hospital cornea retrieval program in our hospital. So no conflict of interest. So as I would like to introduce that this is the condition of eye bank in Indonesia, which mostly handled by the Eye Bank of Indonesia. It's not the national eye bank, but it's a voluntary eye bank, which already start their collecting data from maybe 20 years ago, and then now we are developing our hospital eye bank, which come from the government support of the eye bank. Okay, so this is the corneal blind issue in Indonesia. The leading cause is still the infection and also the PBK, which commonly found among farmers and also fisheries related to the occupation. And the prevalence of corneal scarring is about 1% in both eye and 0.5 in one eye. And then in our hospital, the recipient waiting list is around 165 people, and since waiting up until 2022. The Bank Mata Indonesia, the community-based eye bank, support the local donor cornea from around 250 per year. Based on that kind of background, we start to think about developing the hospital corneal retrieval program, which have a reliable medical history, and we learn also from the India that the younger individual and reduction the time of interval and cost effective. So finally, we try to learn from several papers mentioned about how the hospital retrieval corneal program will give increase on the utilization of the cornea. And then we also learn about some religious causes, the family not satisfied with the hospital treatment, like some of these kind of lists in the table, is we should understand the difference in social condition, which can play a role in counseling method and approach of potential donor. That's why we try to manage a counseling system in our eye bank. So we know that the role of counselor and also the health worker could influence the 68% of donor families, and also the health worker interaction with the patient and also the family during the treatment affect trust in organ donation, and therefore the collaboration between the entire system of the hospital will play a crucial role in developing the HCRP. So I would like to talk about the experience in our developing cornea retrieval program in our hospital. So this is in the eye bank in the tertiary government-supported hospital in Indonesia, in Jakarta. It unit structurally beyond the hospital director, and we coordinate with the transplant unit in our hospital. It consists of multidisciplinary team, which consists of ophthalmologists, psychiatrists, internists from the palliative subspecialty, the forensic doctor, nurses, medical social worker, and also the laboratory analysts. So we start with developing the counseling curriculum, and then we also train the eye bank technician. We send 3 of our eye bank technician to Nepal. Thank you very much for having our technician there. So because we just start our eye bank on last year, October, so it's very small step for our hospital eye bank. And then we also have the coordinator with the transplant center in our hospital. And we also have the affiliated with the Indonesian National Brain Death Referral System. Thankfully, we collect 1 donor from the brain death person suggested from the Indonesian National System. And then we also do the online counseling. So when we have one single potential donor, we also offer the online counseling and also the offline counseling. It really helps for the potential donor to make their decision. And also we also perform the eye bank roadshow through whole the hospital, because we need to introduce our system in our whole hospital. And we also the raising awareness regarding the religion matter, and also all the hospital banner, and we also make online education videos through the hospital waiting room. And we also try to develop our own eye bank app. We'll develop the donor registration, the death alert, the allocation, and also the waiting list and grading score. We learned a lot from previous presentation from all the eye bank, that how do we develop the grading system, and also the decided which one is the potential recipient, and also for the follow-up information. So what kind of difficulties that we found? There's still a stigma and awareness, like the religion, family approval, cornea recipient, and also the organ trade or trafficking. And also we have difficulties including the importation. Like right now we cannot get any donor from abroad, because some problem in the bureaucracy of our custom and tax. So since October, we cannot get any other donor imported from, usually from Nepal and from the US. That's still we try to manage it as our problem. And we still try to collect grant for developing the iBank and then get the fund from the government and also from the NGO. I think that's all. Thank you very much. Okay. Thank you very much. Thank you very much. Yeah. Yeah. Thank you.
For you, because the next session people have already here.
Good morning, everyone. I'm going to talk about the tech revolution in iBanking, innovations in the training for the next decade. About the history and evolution of the iBanking. In early days, iBanking relied on the rudimentary methods for tissue collection, storage, often resulting in limited success rates for transplants. But now, with the significant advancements, such as improved storage solutions, most of us are using the intermediate solution now. Surgical techniques, we are moving towards the increasing availability of the corneal tissues as well. The evolving landscape of iBanking. The field of iBanking, as we all know, is constantly evolving, driven by advancements in technology, regulations, and research as well. And to ensure the continued success of eye donation, evaluation, transplantation, we need to adapt to the robust training programs so that all the iBanking professionals can move with this technology revolution. And through trainings, we need to embrace the technology revolution and prepare our professionals for the next decade of iBanking innovations. They need to move with the time now. iBanking is a dynamic field, and we all know that. In last 10 years, a lot has been changed. And when we are talking about technology and innovations, let me talk about the latest technology innovation which was done. A cornea was transported through the drone. It was a joint project with ICMR, AIMS, and Dr. Shroff Charity Eye Hospital. Within 40 minutes, the cornea was transported and it was transplanted in the hospital. And I just want to highlight it here that there was no professional involved here. You see the technicians who were actually working with the drone technicians to fly the corneas. Now coming back to the training and the development, we all know that the training and development matters for everyone who is sitting here and all the iBankers, because for the efficient processes, for the quality assurance, for the patient outcomes. And in the context of the tech revolution, the trainings need to equip our professionals to effectively utilize the new technologies and to maintain the quality amidst these evolving practices. And the challenges in developing the training programs are, we all work in diverse background. Everyone who is sitting here will have their own different kind of problems as well when we talk about diverse background. It's a dynamic field with constantly changing due to technological advancements. We have resource constraints as well involving finances, humans, as well as infrastructure. And of course, the cultural context matters a lot. We have to balance the theory and the practice. Sometimes we have to do those immediate changes even after we have read something in the theory. We need to be flexible as well as we have to standardize a lot of things. And we need to look for the long-term sustainability. If we talk about the training methodologies normally used in the ophthalmic practices and healthcare, we talk about the classroom lectures, with workshops and seminars, practical training sessions, on simulation-based learnings, on-the-job trainings, as well as the e-learning modules. In iBanking, we are working on most of it, but we have to focus now with the evolving technology on the simulation-based trainings as well as the e-learning modules. I'll not go into in this, I'll just show you a picture here. So if we talk about technology, we need to go more on the virtual trainings, online workshops, distance learning, and this is not new for the ophthalmic practices. We have to just imbibe this in our iBanking practices now. Now when we talk about the technological advancements in iBanking, we need to focus more on how can we use the technology to help us in the iBanking. So there are some ideas here. We can have some digital donor screening tools. We can have automated tissue processing and storages. everyone is working on the blockchain right now, Amazon and all those logistic companies. Why can't we use the blockchain for the tissue tracking and the transparency? And also, this is just a dream when we can have an AI-powered corneal evaluation so that we can move towards more automated things. So if we look at the future of the iBank trainings, we can have predictive analysis for the training needs assessment, remote learning and the telemonitoring, AI-powered chatbots for on-demand learning support. So many of the times when we have to ask something, many of the websites have the chatbots, even an Instagram jewelry shop have a chatbot now, but iBankers don't have a chatbot which can easily answer the questions. And we need to have an open source platform for global knowledge sharing. We do a lot of work in duplicating work, basically. Someone is doing something in Indonesia, in Bangladesh, in Nepal, in India. We need to have something where we can share our best practices. So at Shroff Hospital, we have a Jagat Singh iBank Training Academy where we provide the world-class trainings to strengthen the global iBanking. These are some of the training programs which we offer. And we have developed these tools, the assessment tools for the eye recovery technicians and the eye donation counselors. And we have collaborated with the DGFG, which is an iBank in Germany, iBank and Tissue Bank in Germany. And we are working on developing an e-learning platform. Once it is developed, we will be working on making it more open for everyone's use, and to have a training academy which is more international, so that we don't have to work again and again on the same training programs. And just, ma'am, I'll just take 30 seconds of yours. And how can we use AI? This whole video I have prepared for an e-learning module, only using the AI. I haven't done anything myself. It was just a Word document given, and then everything was done by the AI. There is a voice also which is not coming here, but it is a tool which was, a presentation which was made in 5 minutes using the AI. So thank you so much for the patient listening. The key takeaways we have are the role of technology shaping the next decade of iBank training, need for collaborations between iBanks, technology firms, and policymakers, and we need to continue learning as a key to sustaining the advancements. Thank you so much for giving me the opportunity to present here.
Thank you, Rakhi. This is the end of the session.
I'll request
So
all the speaker to
all the
conveners to
speakers
come for
to
the photographs.
For
Sir.
photograph.